Thank you, Helen. Thank you for inviting us this afternoon. We're really pleased to be here to explain the role of the clinical nurse specialist and also how we as clinical nurse specialists can support patients with cholangiocarcinoma and their families. So for a bit of background, my name's Louise Jones, this is Margaret Griffin, and we are hepatobiliary clinical nurse specialists. We work in a merged trust called Liverpool University Hospitals Foundation Trust, and we're based in the Aintree Hospital. It's a busy tertiary service with a hepatobiliary liver surgical service that has extensive experience in the management of cholangiocarcinoma. Patients are referred to us from at least 15 external trusts spanning Merseyside, Cheshire, North Wales and the Isle of Man, and we also do receive some referrals from GP practices. The patients are discussed at a weekly primary liver multidisciplinary team meeting, and following this, those who are being considered for surgery are then referred into the surgical service and into the clinic, and that's where we'll meet the patients for the first time. I think we always say it's important to recognise that referral directly into the surgical clinic doesn't always guarantee surgery, and this is because it's such a complex pathway and for reasons that we're going to go through throughout this presentation and how our role affects this as well.
So what is cholangiocarcinoma? It's a cancer of the bile ducts and it can grow in the bile ducts within the liver, and then it's called intrahepatic cholangiocarcinoma, and it can grow in the bile ducts outside of the liver, and that's when it's called extrahepatic cholangiocarcinoma.
So many factors guide our treatment pathway and they influence what treatments can be offered to the patients. We know that cholangiocarcinoma is a complex disease requiring complex treatments, and this in turn impacts on the decision making. It's imperative we feel that patients have the opportunity to be discussed at a specialist or tertiary centre, one with experience in managing cholangiocarcinoma. And with this in mind, we can guide as clinical nurse specialists and with our wider team, patient expectations of what's available and what's possible, and ensure that the patients are being considered for all treatment options and all current trials. And by being referred to the specialist tertiary centre, they then in turn benefit from the expertise of the hepatologist clinical nurse specialists, the radiologists, both from the imaging point of view, that's your CT scans, your MRI scans, and also the interventions that are required in radiology. They also get access to the clinical nurse specialist team, to the specialist oncologist, and also to the surgeons as well. The next factor we need to consider is patient choice and the information needs. We know sometimes there's a mismatch between what the patient expects and the treatments that they are suitable for, and it's our role as clinical nurse specialists to help to navigate this gap. And finally, the influence of the family and the carers. This needs to be acknowledged within the patient pathway and also discussed together with what the patient wishes are as well.
So, if surgery is an option, we need to make sure that the patient's fit enough to undergo a major complex operation. And we often equate this surgery to running a marathon or to climbing a mountain. Some patients are jaundiced when they come to see us. The cholangiocarcinoma, the tumour can block the bile duct, making the liver congested and preventing the bile from flowing in the right direction. So managing jaundice is key. For the patient, jaundice can be debilitating. It can cause nausea, it reduces appetite, which leads to weight loss, and it can cause muscle wastage. It causes extreme fatigue and itching, which can in turn prevent the patient from getting enough rest, and it can also affect how the patient sees themselves. For some patients, jaundice is a constant reminder that they've got a cancer. So interventions to relieve jaundice also brings the risk of cholangitis, which is bile duct infection, and also the possibility of future block stents. So in order to address these issues, we draw upon the expertise of our hepatology and intervention radiology colleagues. These are specialists in helping to drain the liver. Some of you may already be aware of these procedures, such as ERCP, which is an endoscopy procedure to investigate and temporarily relieve the bile duct blockage, which may arise from cholangiocarcinoma, and PTC, which is a similar principle where the bile ducts are punctured directly through the abdominal skin to relieve the biliary blockage. Patients have to undergo an in-depth pre-op workup to carry out an accurate assessment. We use cardiopulmonary exercise testing to assess the patient's ability to tolerate surgery, and we use the expertise of our specialist liver anaesthetist to interpret the individual patient's risks of surgical complications in a dedicated pre-op clinic. This can help the patient to make an informed decision and provides them with accurate information. As we've shown, surgery for cholangiocarcinoma requires commitment from the patient and their family. There are multiple hospital visits needed, and engagement from the patient and family is crucial. Some of our patients have a 6-hour round trip to get to any hospital appointment. So to illustrate this, one of our patients who had a resection in May 2021, she's in her early 50s and is a carer for her son with a learning disability. Her husband is self-employed and he is the sole wage earner. So in order to get to the point of surgery, she needed an ERCP, multiple attempts at a PTC, a stage and laparoscopy and a portal vein embolisation. This resulted in 10 outpatient appointments, 4 outpatient scans and 4 admissions to hospital in a 4-month period, totaling 42 days, not including a resection surgery. So we can't underestimate the physical, psychological and financial burden that this places on the patient and their family, and we need to be transparent from the outset about what is required. And we can't not mention the C word with the impact COVID has had on our services and the challenges that this has brought. The delayed access to investigations and the possibility of postponed surgery dates do still factor in our service, but they are improving and we are in a better place now. And COVID restrictions for visitors have been a challenge to overcome. It's hard to be away from loved ones at such a stressful time. However, this is also now improving. So the other hurdles to get over when we're thinking about surgery are more technical. So we need to make sure that the cancer is able to be removed with surgery. So we do a stage and laparoscopy, which is a keyhole surgery to check whether the cholangiocarcinoma has spread to the peritoneum, which is the membrane lining the abdomen. We need to check that the remaining liver can support the patient after surgery by reviewing scans such as CT and MR and asking our radiology colleagues to measure the volume of the liver that will be left behind. Sometimes a portal vein embolisation is needed to grow the size of the liver that will be left behind, and this can take between 4 and 6 weeks to work. We need detailed preoperative scans to check whether the cancer has grown before surgery, and also there's a careful assessment made during the operation to check for disease in the lymph nodes outside the field of resection. Any of the above challenges and hurdles could prevent surgery, and therefore the treatment plan can change. We recognise that the patient and their family have to process this complex information and live with the uncertainty that their treatment plan may change if any of the above hurdles are encountered in their pathway, which can be a lengthy one.
So, how does the CNS support the patient? Well, first and foremost, in order for the patient to undergo the surgery, we need to be effective, honest and accurate communicators. And that's from all the team members about the possible treatments for that patient. We're very lucky in Liverpool. We work closely with our hepatobiliary surgical colleagues, and together we help patients and their families to understand the complexity of undertaking surgery, including both the long and the short-term consequences. We also need to understand how any of these factors affect the patient's ability to live the life they want to live after surgery and understand the impact on their quality of life. So in order to provide accurate information, our unit reviewed 85 patients who'd undergone surgery for extrahepatic cholangiocarcinoma. And at least one complication was noted after surgery, and 20% of our patients were readmitted for an intervention. And this could be to treat a collection or an infection. And it's important that we can provide details like this to the patients when they're making such big decisions. So moving on to managing uncertainty, well, how do we manage this? Well, as we've alluded to, this is a complex, often lengthy pathway for the patient, and it's subject to change. Patients and their families need total understanding of the reasons why they can and cannot have certain treatments, so they understand the treatment plan. They're also entitled to a second opinion, and sometimes this is helpful, as then the patient knows that they've explored all of their options. Another aspect of uncertainty relates to patient surveillance. So we inform the patients that they're going to be under surveillance for 10 years following surgery, and the reasons for this need to be explained and understood, because we do know that this disease can recur. So we see the CNS, the clinical nurse specialist role, as being crucial in managing the patient's expectations. We ensure that the patient and the family understand the treatment plan. We'll repeat information as often as required, allowing patients the time to absorb and understand the information at their own pace. We provide personalised information in appropriate formats, so we have access to a patient pathway video. There's a written personalised treatment plan we provide, and we also signpost to reliable sources of information and support. So for instance, Macmillan Cancer Support and AMMF information as well. We know that the internet and Dr. Google can be a minefield, so it's often inappropriate information, and this then in turn can raise unreal expectations of what's possible for a patient, particularly in the UK. We also have tools that we can use to assess what's important to the patient. We use a tool called the Holistic Needs Assessment, and this is a tool of different a assessment tool that comes with different headings, so we can look at emotional concerns, practical concerns, physical concerns, and it helps us to explore what is important to the person and how this treatment could impact them. The assessment can be repeated at various stages. Sometimes we have access to this assessment being done in the community by community navigators, and the concerns and expectations we've noticed can and often do change with the treatment plan and the intent of that plan as well. So is it all worth it? Well, a good example of this is a patient in her late 70s who we reviewed to consider surgery, and after in-depth consultations and exploring what was important to her, she decided in the end to opt against surgery because being with her family and feeling well was the most important thing for her, and she valued a shorter time, but in order that she could remain well to attend her granddaughter's graduation. She accepted a palliative treatment pathway, and she was then referred on to oncology. But in order to come to that decision, she had many outpatient appointments, and we took the time, as I've said earlier, for her to absorb and make an informed decision. I think also an important message to take away is that the clinical nurse specialist is the one consistent professional throughout the patient pathway. We're present in clinic, on the telephone, we visit patients when they're in patients for their surgery, and then for future follow-up when they attend the clinic. And to illustrate this, the patient that Margie spoke about earlier, we look back at her contacts with Margie, and she'd already had 19 contacts up to the point of her surgery. So then probably went on to have even more than 19 after that. And that's okay, because we want the patients to feel that they are supported. There's no stupid questions, because if you're thinking it, then someone else is thinking that question too. And I'm pleased to say that that patient's now almost completed her adjuvant chemotherapy and is feeling well and supporting her son.
So how else do we support the patient and their family? So we're very lucky in Liverpool to have access to an innovative rehabilitation team, which consists of physiotherapists, dietitian, and an occupational therapist. And we work closely with this team throughout the pre-op pathway, inpatient stay, and the recovery phase, including joint clinic appointments if needed. We make the initial referral early because we know that input pre-operatively helps support the patient's well-being with the use of measurable outcomes that help the patient see the progress that they're making. We can identify interventions that can optimise the patient, for example, rectifying vitamin and mineral deficiencies, and providing the patient with advice on diet, food supplements, and a personalised exercise plan. During the recovery period, we work closely with this team to identify and support patients who are failing to thrive and provide early intervention. We know that the behaviour of the cholangiocarcinoma is out of a patient's control. However, the clinical nurse specialist and the rehabilitation team can together support the patient to take back control and act upon aspects of their life that they continue to influence. Carer and family engagement is crucial, keeping everyone that is important to the patient in the loop. The impact of COVID has meant that the CNS often bridges the gap between the patient and their family during their inpatient stay. And feedback from families has shown us that they benefit from reliable, regular updates from a CNS that they know and trust. The CNS is also realistic with the patient's family about the support that they will need after discharge. And then the HPB clinical nurse specialist at the specialist centre also has a close working relationship with the local referring hospital. So keeping them up to date with whatever is happening with the patient and trying to arrange investigations done locally wherever it's possible, because we know that this is the patient's preference. And if the patient's treatment plan needs to change, we ensure that the team who will take over the patient's management has the right information that they need to support the patient and their family and ensure a smooth transition of care in what can be a very, very stressful time. And another aspect of our CNS role is to facilitate patients meeting the right person to meet their needs. So, for example, we can refer on to the psychologist, the benefits advisor, and community teams as appropriate. So in summary, working together can enhance the patient pathway and support the patients and the family's understanding of this complex disease.
So to conclude, I hope that we've helped you to understand more about our clinical nurse specialist role today. It's vitally important that the patient and the family are engaged at every point in the pathway, and the clinical nurse specialist is key to ensuring that this happens. We need to recognise that a cholangiocarcinoma treatment pathway brings uncertainty and change, and clinical nurse specialists, our aim is to effectively manage the patient pathway, and then we can minimise the stress that this can cause and help to build up the resilience to cope with whatever treatment is appropriate for that patient. Managing cholangiocarcinoma does require effective teamwork. No individual can do it alone. As I said earlier, I'm very lucky to work with a skilled team in Liverpool, and together with my clinical nurse specialist colleagues and consultant surgeons, we provide the skill, expertise, excellent communication, together with the time needed to optimise that patient pathway. And I was really privileged this week to receive a silver award from the Chief Nursing Officer of England for nursing excellence. And this was in recognition for not just my determination, but I feel that I only got this award through the backing of being in such a good team. Our determination to improve care for patients with cholangiocarcinoma and cancer and their families, and also in recognition for my contribution to hepatobiliary cancers nationally, and also the national work that I've done on clinical nurse specialist competencies to ensure a skilled workforce for looking after patients.
So we felt that it's only right to give the last word to one of our patients. So this is from a 75-year-old gentleman who had a really difficult pathway pre and post-operatively, and his granddaughter was born while he was recovering from surgery. He and his wife now look after his grandchild and keep very busy, and this was 4 years ago. We just received this Christmas card in December of 2021, and it helps to explain why we do what we do.
Well, huge thanks to you both for such an informative and inspirational presentation, and massive congratulations on that award. I know it was very, very well deserved, and you're very generously passing it on to your team, but you know, the work you do is phenomenal. And actually, as I was listening to you, I couldn't help thinking, you know, if only all those with cholangiocarcinoma had clinical nurse specialists like Louise and Margaret and their team to turn to and to help them. So I think you are setting the standard, and I think this is something, maybe we should have conversations afterwards. We need to set up training schools, I think. But thank you so much. We're going to open for questions now for Margaret and Louise. If you're here with us in person, or if you're virtual, either way you can use the app and submit your questions in the chat forum. If you're here with us now and you have a question, you can raise your hand to ask a question. I'm going to invite Gary to come to the platform to help us moderate the questions. And I think he said earlier that were already questions coming through. So if you're ready to start with the question, Gary.
Yeah, so we're joined by around about 75 virtual attendees. And as Helen mentioned, it's an opportunity for you in the room to ask a question to our panel here. We have had a couple of questions come in from the virtual audience. The first one, and I won't direct any individual, you can argue between yourself. So one of the questions that has come in is, what's the usual timeline for a confirmed case of stage 4 with METs to liver and lymph nodes to start of treatment? You can read it yourself if you want to. Here we go.
So it's a confirmed state. So it's already been confirmed. Okay. So we would discuss it at the multidisciplinary team meeting, and then the patient would then be referred on to start chemotherapy with the specialist hepatobiliary oncologist. So usually we try to ensure that referral. I think the NHS class urgent is within 2 weeks. So
to get an appointment if they've got a tissue diagnosis of cholangiocarcinoma.
Thank you. So before we go to another question from virtual attendees, are there any other questions from the audience? So no hands, so we go to, so another question that's came in. What's the procedure if a patient hasn't been given a CNS support or adequate support? So I think this is looking at if a patient doesn't have access to a clinical nurse specialist, what can they do to advocate for themselves to try and get access to a CNS or find similar support?
So we're within our roles, we're adopted. We're not actually paid for by Macmillan Cancer Support, but we're adopted by them. So we're badged by Macmillan Cancer Support. So we're very much pro recommending that they would ring the Macmillan Cancer Support helpline, which is a free helpline, and they could get some advice through there. They also provide a patient buddy system as well. So they try and look for someone who's in a similar situation and can provide it in that way. But often there are some clinical nurse specialists, depends where they are throughout the country, but some hospitals do have clinical nurse specialists. They just might be under the wrong team at the time, and it's a matter of navigating to find that support within that hospital as well.
And the AMMF as well. We always recommend
the AMMF because obviously the patient forum on there. Yeah.
Excellent. So we do have, let's go, just wait for James, go to a question in the room.
Thank you so much for sharing your best practice model. I'm curious to know, how did you come to develop this model that you have in place? And are there any elements that other centers could start to apply today in order to help and benefit patients?
Yeah. I think it's something that's just evolved over time.
Yeah.
In terms of the rehabilitation service, that was some funding that we got from Macmillan, and we really feel that does help really helps our patients, regardless of whether they're going to have surgery or chemotherapy or best supportive care. I think in terms of the information that we provide, we're sort of led by how much the patients and their family would like to know. When we meet them, we try and sort of handwrite sort of like a personalised treatment plan for them when we're in clinic, and then back that up with literature from AMMF. If they are going to have surgery, we have like an enhanced recovery booklet and a video that they can use. But it's a lot of it is led by what the patient wants. Isn't it?
Yeah. I think Margie's right. It's evolved over time. Margie's been on the team for 9 years. I've been 20 years this year, so it's a long time. So I think over time we've just built it up, and that's through experience as well. So, and we're always, I think the other thing is we're keen to learn all the time. So we'll look at what other teams are doing and see, well, because is that translatable into our team? And, I don't believe in reinventing the wheel. So we'll see what else is happening and try and keep up to date with everything. And you're going to bump into people who are the same like-mindedness, and then you can, enhance your practice. So.
Yeah. And I think you don't always get it right first time. And I think if a patient tells you that you could have done something in a different way that all might have helped them, you learn from that as well.
Yeah,
don't you?
and Margaret just hit the nail on the head there as well. Involving the patients for feedback is really key. We do regularly ask for feedback, and we give out questionnaires. Just so that we can see, what is working, because we might think it's working and the patients will know you're pitching it too high or too low, or I would have preferred it in this format, and then we can, tailor make our practice accordingly. But we're still learning.
Yeah.
Thank you both. So before we go to another virtual question, we're going to go to table 2.
Okay. Congratulations, firstly, on your best practice model. I think it's fantastic. But just extending from this lady's question, in terms of the great work you've done, do you have an established CNS network in the UK, obviously aside from the AMMF, where you can actually share with other CNS nurses what you've done? And thinking more beyond that in terms of Europe, of a network where you can share this is how it should be done?
So I've just finished a term as one of the national leads for ORGIS, the Association of Upper GI Surgery, for the nurse role. So we did share a lot through that. Obviously, it was really tricky. The COVID, I know COVID's still around, but the 2 years during COVID was really tricky. Things did slow down somewhat with networking. I know we had to go on to Zoom, but we were pulled from our post as well for many months and had to set up in a new hospital and things like that. So that's been a bit of a dormant time. But the other thing that we've done is locally, we also have a really good group, which is our Hepatobiliary Nurse Forum. And so we invite all the referring hospitals to send their local clinical nurse specialists, and we do a meeting. Again, pre-COVID, it was we used to do it twice a year, but worked really well. And what we try and do in that situation was we'd have a speaker from the centre talking about, some of the treatments, but we'd also invest as much time into roundtable discussion and networking with our referrers. And it was really good to get that feedback of what was working well. Were patients getting any delay getting referred into the centre, or were multidisciplinary team outcomes, were they easy to understand and interpret for them to relate to patients? And we've learned so much from that. And we tend to find that, I know that one of our surgical colleagues came to present on, how do we do surgery for cholangiocarcinoma, and then he wanted to stay and listen to the round table because it's really informative. And so, that's another really good local thing that we do as well. So.
Thank you. So we're running short on time, but there are several very good questions which I'm going to quickly try and get through. Okay. So speed answers, please.
Okay, speed answers.
No. So one of the questions, I'm going to paraphrase it slightly, is there any way we can speed up the time to results as the anxiety heightens with time? And in the UK, it's taken several weeks for results. Yeah. It's most important that we, as patients, get feedback as soon as possible. So is there a way that we can expedite?
I think what we try and do is we're constantly chasing, aren't we? We're like on the phone, emailing, we're chasing to get that scan date brought forward, we're chasing to the histopathologist to, can we get that result through? And we even try and accommodate earlier clinic appointments in that pathway. I think we are conscious of, especially the cancer pathway timing. So we do, I think people in the hospitals see us and hide because we're constantly asking, we need more, we need it quicker. Things. So I think it's about being a proactive workforce and trying to, but it's difficult because there's lots of other things that are out of our control sometimes. But we do try and push for those results as quick as we can.
And we always try and accommodate people. As soon as we've got a scan result, we try and juggle the clinic around, and always try and accommodate people because we understand that's one of the hardest parts of the process.
The unknown, definitely.
The unknown.
Yeah. Of course. So before we go, I think we go to a final question from the audience, from the virtual attendees. You mentioned in your presentation the 10. I heard you speak of the 10-year follow-up. My follow-up period was for 5 years from 2011. When was this excellent change made?
Well, I think I'm right in saying we've always done, our team have always done 10 years. So that's probably something that we've just always instilled. We do it for, we look after different types of liver cancer and we follow everybody up. We've always had a 10-year follow-up since I can remember. So I think it's just different practices and different trusts. Excellent. So I think we are running tight on time now, but not to close the session, I'll leave that to Helen to do. But there's a nice comment that's come in from a patient and a good friend of AMMF, Malcolm Robinson, that has said, not really a question, but an expression of thanks for the wonderful support I experienced from the specialist nurse team at Leeds General Infirmary. They were always very accessible and able to provide information and advice at the end of a phone or in person. I can recall to this day the secret greeting from the specialist nurse who was aware of the waiting time to be given, the results of a 6-week monthly scan. A quick smile and a hug were all that needed to reassure that the 45-minute waiting time to hear the specialist pronounce passed as quickly as possible. So I think that was a nice way just to draw close to this session.
Well, thank you, Malcolm, for that wonderful message, and we're so glad to hear from you. And to know that there are other teams with wonderful clinical nurse specialists too. Thank you.
And there are many, many questions, Helen, that we'll probably need to follow up with at a later date.
We will try. If your question hasn't been answered, we will try and pass them on and get them answered if at all possible. But it just to wind up this session, I really do want to thank both Louise and Margaret once again, because they really have pulled out all the stops to be here with us this afternoon. And I said it before, I say it again, they are truly inspirational. So thank you both.
Thank you, Helen.